Dr. Viehoever. She's an assistant professor from the Washington University in St. Louis, and she will give a talk about natural history of GNAO1 neurodevelopmental disorder. So.
Okay. So thank you all, and I especially thank the organizers for inviting me to this fabulous meeting. And I'd like to take the opportunity to update everyone on the progress of the natural history study and really inform the community of what we have done, what data we have collected, and really offer it up for collaboration. We really feel that, yes, we have collected this data in conjunction with the Bow Foundation, but we would really like to work with other groups in analyzing this data to really try and maximize the benefit of what and the efforts that both the families and our team have done in collecting this data over the last 4 years. So this study was done, the data was collected primarily at Washington University and St. Louis Children's Hospital in conjunction with the Bow Foundation and University of Virginia. So just to give you a little bit, I thank Dr. Ghilardi for introducing the disorder, and so I won't have to spend time going through the aspects of GNAO1, and we can just talk about the more specifics. So just to tell you a little bit about the story of how this all came about. So in November of 2017, the Bow Foundation invited both families and researchers and clinicians from around the United States, and really streamed it all over the world, to a meeting in conjunction with the Society for Neuroscience meeting. And it was really an amazing and eye-opening experience of the power of what a combined family and scientific conference could do. And when we talked about it afterwards, we all felt that we should do this again, and felt like, well, if we're going to all come together again, we might as well start collecting data. And so that's what we did. So in April 2019, we launched the first annual Joint Family and Scientific Conference and Research Clinic. In April 2020, we had planned to have our second annual. Obviously, that was quickly converted to a virtual forum. And we proceeded to collect virtual data. We converted all of our metrics to a virtual collection with a few exceptions. Then in July through October of 2021, due to funding and time limitations, we elected to only collect data on those subjects where we already had 2 years of data. And then in 2022, we reopened the in-person research clinic and scientific conference. So a little bit about the goals of this. I think it's very important to be clear of, what are you trying to do here? So we really wanted to understand the clinical phenotype, or what does this disease look like, especially over time? How does it change? Because at the point in 2017, we really didn't know. And a lot of us thought that this may be a very progressive disorder that could be fatal. Sure. Okay. And then we wanted to establish the feasibility of a long-term prospective natural history study, which is really the gold standard. That's where you really see how does the disease change over time. And you really need that information before you can move forward with clinical trials, because otherwise you're never going to know whether or not an intervention is working or not. And we knew very early on that we would likely need a rating scale that was very specific to GNAO1 because of the unique factors, the unique features of this disorder compared with other disorders that can cause either epilepsy or movement disorder. And then we really, in keeping this patient-oriented and family-oriented, even though it's not a scientific goal per se, we wanted to generate an initial set of best practice recommendations that families could take with them, because as I've told all of my patients with rare diseases, you have to become the expert, right? The other doctors are not going to know anything about GNAO1. You're going to have to educate the ER doctor, your family practice doctor, and so giving them the power to do so. And you can see the results of these recommendations are in a pamphlet at the back of this venue. So the structure of the research clinic, we set up different stations. So the first station would be information gathering, collecting all the medical records that the family could bring us, filling out questionnaires, getting consent. Then they had a thorough neurologic exam and movement disorder assessment by myself, an epilepsy assessment either by Howard Goodkin or Erica Axine, and then development and motor function assessment by some of the occupational therapists and physical therapists. And the metrics that we chose knowing that these were going to be imperfect, right? But they are also the gold standards that are used in the literature and are well established. So I'm not going to go through them all here, but just to give you an idea of the different things that we were measuring to try and bring some sort of quantification to our assessments. Okay, so in year one, we really didn't know what to expect, but we held this in person over 2 days. We had set our maximum number of families at 20, and I think we had 30 families interested, so we had to turn away families, which we were kind of surprised by. We had one who got sick at the last moment and couldn't come. And the things that we were struck by immediately at the first year was this tremendous variability in both ability levels and movement disorders, because what had been published thus far was the very severe cases that are in the ICUs. And this really broad variety of movement disorders, as Dr. Ghilardi alluded to in her talk. We also noted that many of these kids were very happy. They had very infectious smiles and really did not have the level of psychiatric illness that sometimes we see in other movement disorder patients. And then we uncovered some new symptoms that we had no idea about. This temperature regulation issue, which may be related to autonomic instability. Many families were saying, oh yes, my child doesn't do well with bright light. Some little things that we would have never known had we not done this very extensive review of systems. So in year two, we obviously had to transition to virtual collection of data. It's a blessing and a curse, right? So the blessing side of it is that we were then able to expand who and where we could do the assessments. So we had many more international families, including the group from Spain, and it was very surreal being able to, examine a child in Romania from my bedroom, basically. We added a few other evaluations that, including a survey to try and understand how well what the level of receptive language was. And we did further analysis of what areas were really important to families to try and narrow down some of the data collection elements. We had to eliminate the occupational therapy and the modified Ashworth scale, neither of which could be done remotely. So I'm just going to show you a little clip of how we did this transition.
So we're going to do the same test that we did last year. Does she have all of her braces and everything off already?
She does.
Yep.
All right. Well, let's go ahead and get her ready and we'll get started.
Yeah, reach for daddy's hands. Can you reach?
High fives. What? Hey.
Good,
Like
grab.
that. Yeah, you want to get your unicorn? Here, reach for unicorn.
Unicorn.
From your unicorn, can you reach forward?
So here you can see some of the bradykinesia, or not necessarily bradykinesia, but issues with initiating movement, some motor planning issues. It takes her a while. She knows what she wants to do. It takes her a while to then do it.
High five.
And here you can see some of the action dystonia with some of the twisting, some of the posturing. You can see some overflow in the legs. She's just trying to move her arm, but her legs start moving as well. That's the overflow dystonia.
Okay, can you see her then?
Okay. And so more dystonia with the pointing of the foot, the leg she can't quite get to relax.
Can you lift your hands up in the air?
And minimal amount of chorea right now. But you can see that with the right setup, if the family has a good laptop, has a flat surface, has some tools that they can pull in, like a sofa, or we can come up with ways of doing all of these tests and in the child's home environment. And what we found is that we got much better data collection. Videoing the children in their naturalistic home environment. We got them to participate much more easily than we did in the hospital setting with just a mat, where the kids would kind of freeze up and become anxious because they were afraid that they were going to get poked and prodded. Okay, so that example was a very good example of the movement disorder that I think we see in the majority of our subjects, which is this mixed dystonia chorea. We didn't see a whole lot of chorea from her there. She would have bouts where she would get more wiggly. But that was, I think, the majority of patients that we've seen with this disorder have that type of movement disorder where it can look very much like a dyskinetic cerebral palsy, but then with these episodes of more hyperkinetic movements. In year 3, again, it was all virtual. We did only returning patients, and the goal was to really just establish feasibility of being able to collect this data over multiple years and to try and begin to identify metrics that were changing over time. And then year 4, in June, we had 15 subjects. 2 were new. Unfortunately, thankfully, Dr. Garris from the University of Virginia flew in to take over for myself as I was out for family medical issues. And so some of the clinic we didn't have as many subjects as we would have liked. We had a similar protocol to year 1, except at the time, we knew that the assessment of fine motor and adaptability the P-body was not a very good measure at all. And so our occupational therapists developed a modified version, taking in aspects of the P-body developmental rating scale, as well as other established rating scales based on their experience with the GNAO1 population that they thought would be appropriate. And then they modified most of the objects to include a scale where if you couldn't do the task exactly as prescribed, but you could do it with adaptations, you would get a modified score. So you wouldn't just get 0 if you couldn't do it perfectly. And we felt like that was a better assessment of their true ability. So you can see in the upper picture, one of our star subjects, they're using a really big, thick, fat crayon for her to use, because that is what she uses on a daily basis because it helps her stabilize her grip, where she couldn't do the task with the pencil or crayon that is prescribed by the scale. And so she would have scored a 0. But with this adaptation, it enables a better measure of her actual functional abilities. So in summary, we now have collected data from 50 subjects with at least 1 year of data, and that includes videotaped motor assessments, evaluations of quality of life, and seizure evaluations if they have seizures, and medical history. We have 4 subjects with 2 years of data, 5 with 3 years of data, and 10 superstar subjects that have shown up and participated for 4 years in a row. But we have a waiting list. There are many more families that are interested than we have the bandwidth to include. And that's where it breaks my heart that we can't include all of these patients, because all of these subjects, we need the information from them. And the only way that we can do that is to grow the effort. And unfortunately, that takes funding and manpower. Our youngest subject we enrolled was 2 months, which is unheard of 10 years ago when this disorder was described. And I think one of the things that the families don't appreciate is how different things are in the age of rapid genetic sequencing. And 5 years ago, that would have been unheard of. Unfortunately, and then we also have subjects in their mid-20s. We didn't know that children could survive this long prior to these natural history studies. Unfortunately, we had 2 subjects that were in the cohort that died during the study, one at 7 and one at 8. One of those subjects had epilepsy, the other didn't. The movement disorder child died due to a combination of increased movements and respiratory compromise, and the other child of an unclear cause. And we had, while this was obviously heavily weighted on the US, we were able to include 10 families from Spain, 1 from Romania, 1 from Argentina, 1 from Italy, and 1 from Switzerland. Okay, so characteristics, all had hypotonia as an infant. And this is why this gene needs to be on any hypotonia screening panel, in my opinion, and I've tried to spread that message more widely. You see a child with hypotonia that's not due to a muscle disorder, that we think it's a brain disorder, has a normal brain MRI, this needs to be on your list of differential diagnosis. Okay. All but 1 had some form of motor impairment by the time we examined them, and the 1 subject that did not have motor impairment didn't have motor impairment because the person had DBS, and he virtually had no impairment. But if you turn the DBS off, the motor impairment came back. 13 out of the 50 had epilepsy, and I think that this is somewhat of an ascertainment bias in that those families that are and children who are able to travel did so. And so sometimes the children with epilepsy are more sick, and so it's more difficult for those families to travel and participate. But we also found that, not all were active. And so sometimes the epilepsy can be very mild. Sometimes they only have 2 or 3 seizures in their entire life, and then they're completely seizure-free. There was also this mix of movement disorders. There are cases where there's only dystonia, but it's rare. And 2 of those cases involved DBS, where the hyperkinetic chorea portion was controlled, but the dystonia was not. And sometimes there was still progression to fixed dystonia. Whether or not that can be avoided in the future with programming or implanting earlier, I think is still unclear. And then there were some with just hypotonia, although in my opinion, as these children age and begin developing a little bit more voluntary movement, then you start to see the dystonia and the chorea emerge. But sometimes they can be just hypotonic for several years. So again, there's a huge range of motor disability. Okay, so if you look at on the left is a schematic of what we call the GMFCS, or Gross Motor Function Classification Scale. It kind of gives you a broad category of what's the mobility of a child like. And there were 13% of our subjects had a level 1, which means they could walk up the stairs carrying something. Although most of our subjects were in a level 5, which means that they cannot sit or stand on their own. But the level of motor disability didn't correlate with the abnormal movements, which is really interesting, right? So it's not the chorea and the dystonia that drives the overall disability. In my anecdotal experience, it's the hypotonia. And the level of motor disability did not correlate with the genotype, and data that I won't show you, but I can show you later if you're interested. So looking at these metrics then, are we measuring the right things? Maybe, maybe not. The Korea scale looking at Korea had inaccuracies due to the inherent variability of the hyperkinetic movements throughout the day and between days, as I'm sure all the families here can attest to. There's a ceiling effect of the Burke-Van Marsden. The gross motor function scale was good because it measured the true abilities in a even for the kids who were who didn't move very much at all, but it takes a long time. It takes an hour. And it has to have somebody who's very highly trained. The Peabody scale was no good. And the CP child really is a better measure of caregiver burden. And the caregiver burden doesn't necessarily change even if the child improves. Because if the child is still in a wheelchair or the child still needs assistance in activities of daily living, the child care burden may be the same. So I'm not going to go into treatments. The bottom line is we really didn't find any epilepsy treatment or movement disorder medications that worked a whole lot better than others. You can see the recommendations that we have in the pamphlets in the back. The one caveat to that would be deep brain stimulation. And what we see in deep brain stimulation is that the hyperkinetic movements are the things that improve the most. Fixed dystonia usually doesn't improve. But we're going to hear more talks about that later. So, in conclusion, there's a huge breadth of phenotypic variation, even with the same mutation. So you can have the same mutation and have completely different pictures of what the subject looks like. And I think that there are many, many more people out there with GNAO1 that we don't know about because they haven't been tested. Now, I think this is changing, and I think our numbers will grow as testing increases. We can't ignore the non-neurologic symptoms. The GI issues can be real and can drive the movement disorder. Sometimes, and they can be very severe, from everything from just constipation, which is very common, to needing both a GJ and an ostomy out because of very poor GI motility. And this temperature dysregulation that a lot of families talk about, I don't know if it's a form thrust or a partial presentation of an underlying autonomic instability. I think it probably is. And then as far as moving forward with the research, I think we need to be flexible with our data collection so that we measure the true abilities and disabilities of the subjects that we're looking at. We need to build scales that allow for adaptations, and not just, well, we do want to be systematic. We also want to be accurate. And we need to be very careful of ceiling and floor effects because of this large range of variability. And we need better objective measures of communication and cognitive functioning, which is common to many, many disorders of mobility in children. Because, as many people know, the cognitive functioning of many of our GNAO1 subjects is normal. So I really wanted to open this up to a bigger collaboration and sharing of data when and where it's possible. I think we do need to develop and validate a rating scale before it can be used and rigorously test that. And I think we should look to other diseases that have made more progress, like Rett syndrome, like Batten's disease, where they've been through the trenches and they now have treatments, disease-specific treatments that are approved and being given to children and adults with their disorders. And then I think we need to look at novel possibilities for potential outcome measures. And since I'm out of time, I'm just going to show this slide as something, if anybody is interested in some of the new work that we're doing with accelerometers, we can talk about it later. And there are our acknowledgements.
So thank you very much. This is very useful and pioneer work for all the study about natural history. I think we have time for just one little question. Yes?
So as parents, should we contact you for this study?
Yes, it's a little bit unclear exactly how the study is going to move forward. You know, we do plan to continue to collect data. We're not going to collect data this year, but starting next year, in conjunction with the Bow Foundation, exactly when and where that will be and what form is unknown and will in partly be due to funding. But yes, please stay in touch, and I'm hoping to develop a more systematic way of families who are interested, who like how to document that you're interested and keep you on a list. But yes. Okay.